I'll go ahead and get started since we're recording for everyone who might not have been able to join us this evening. Thank you for joining Virginia Health Catalyst for our mid-session policy update. I'll be talking through a little bit of what we've been working on this session, and we will be recording this and sending this out as our policy update this week so that everyone who might not have been able to join us will get all this information as well, and you'll have this to look back on. My name is Lauren Eggleton. I'm the Senior Policy Manager with Virginia Health Catalyst, and I'll be leading our policy update today. And we'd like to just ground our meetings with this reminder of our mission, that at Virginia Health Catalyst, we're committed to ensuring that all Virginians have access to comprehensive health care that includes oral health. Our mission is to eliminate barriers to optimal health by addressing inequities and inefficiencies within the healthcare system. And we achieve health equity through our multifaceted approach. Our 4 pillars of public health policy, public awareness, and clinical and community care are connected with a through line of health equity. And we believe that education, advocacy, and technical support are essential for driving systemic change. And by fostering open communication, building strong partnerships, striving for excellence, and respecting the needs and voices of communities, we place equity at the forefront of healthcare landscape. And we are committed to transforming the Virginia healthcare landscape to become more inclusive and accessible, ensuring that everyone in our state has the opportunity to thrive. So I hope everyone's had a great start to the year. I know that we've had a busy one with this time and session moving quickly. We're excited to update you on all our advocacy work so far in 2026 and what we plan today, advocating for our policy priorities moving forward. The picture here is our Healthcare for All Virginians Coalition from our Advocacy Day, and their Lieutenant Governor Hashmi right front and center with us. Today, I want to remind everyone of what our legislative priorities were going into this session and the new Spanberger administration priorities. Then we'll move into the meat and potatoes of checking in on where bills and budget investments are as of today, or as of last night when I updated these slides. Things are moving very quickly right now, so I'm sure things have been advanced during the day today even, and what that means for our policy work going forward. I've included a few slides at the end with some more information on Virginia's Rural Health Transformation Plan at the end, because there's a hopeful note there to end on and some information for you to reflect on. And we also want this time to be a resource for you all here with us live. So feel free to come off mute or ask any questions that you have, and I'll be happy to answer those. People watching after the fact might benefit from your questions, so don't be afraid to come off mute and ask me in the middle of the presentation. So Catalyst legislative priorities this session fall into at least one of these 3 buckets we have here for you. Under access, Catalyst supports policies that remove barriers to healthcare and strengthen the healthcare safety net across the lifespan. Our focus is on expanding and safeguarding safety nets, including school-based health centers. We aim to integrate oral health into primary, maternal, and chronic care, protect access to maternal and child health services, reduce coverage gaps and churn, and ensure the preservation of Medicaid and public health care coverage. Under well-being, Catalyst advocates for policies that improve oral health conditions beyond the walls of the clinics. We prioritize whole person investments in safe drinking water, environmental health, food security, housing stability, and community safety, along with modernizing health data systems to improve transparency, accountability, and equity outcomes. And under capacity, Catalyst focuses on strengthening the people, infrastructure, and systems that deliver care, especially in underserved communities. We support incentives to practice in high needs areas, expand residency and training programs, stronger recruitment and retention pipelines, recognition of caregivers and community health workers, and reduced administrative burdens that limit provider capacity. And we're very happy to see some overlap with the priorities of the new administration. So I also want to share what the Spanberger administration is calling the Affordable Virginia Agenda in collaboration with the General Assembly. While we're not tracking all of the legislation associated with this plan, I know I'm not a specialist on energy policy. There are some great bills and incentives being pushed through this effort that support healthcare access, the healthcare workforce, and support services that address the social determinants of health. You can learn more about each of these initiatives on the administration's website. But you'll see a strong focus within the healthcare area on prescription drug pricing, limiting the amount of prior authorizations required when accessing care, healthcare workforce investments, addressing the ACA premium assistance that's needed after the federal expiration, and eliminating the fees on premiums that is also impacting those families. We're also watching a pretty large body of housing access bills that provide a lot of renter protections, affordable housing programs, both for renters and owners, preserving affordable properties in the long term, developing mixed income housing through loans and incentives for developers, and the eviction reduction program. So now we're going to dig into the bills we've been tracking in 2026. We do have a bill tracker available on our website where you can follow the latest in real time on everything that we're following. For the interest of this presentation, I focused on the bills that we're actively supporting, but there are dozens of bills that we're monitoring that are of interest to the healthcare system and the social safety net. So you can go there to look a little bit more into those bills if you're interested. So I personally like to start at the beginning to lay the groundwork for anyone who might not work in the policy world. So I've taken a stab at making my quick and dirty Schoolhouse Rock, How a Bill Becomes a Law, Virginia General Assembly edition, just to attempt to capture our legislative process in one slide so you can understand where we are right now. So a bill starts out as an idea, and that idea can come from anybody in the community to solve a problem or make Virginia a better place. And that idea is drafted into a bill that the legislator championing the idea introduces into their chamber, either the House or the Senate. This bill is then assigned to a committee or a subcommittee where most of the debate and the workshopping happens. So this is where the public is invited to share public comments and amendments might be made to improve the bill. If the subcommittee or committee votes favorably in all the committees that might need to put in their 2 cents on the bill is reported up into higher committees and eventually the full chamber floor for all of the delegates or all of the senators to vote on. So at that point, the bill has passed its original chamber. So then the really key pivotal date, which this year was February 18th, happens. That's crossover day, where all the bills that start in the House switch over to the Senate. All the bills that start in the Senate switch over to the House. And they go through the same process where all of the legislators get to put in their opinion and vote on each bill. So any bills that haven't passed their chamber at this point may fail for the year. A bill has to pass its chamber by crossover day. So the two chambers debate, and they might offer amendments to the other. If there's disagreement between the chambers, they go to what's called a conference committee. So members from the House and the Senate get together. They negotiate any differences until hopefully one final version of a bill is passed by both chambers, at which point the bill is passed over to Governor Spanberger, who can then choose to either veto it, recommend amendments for the General Assembly to consider, or sign it directly into law. I also like to note that there are very important decisions that are made in the administration and the execution of those laws after they're passed that are refined outside of the General Assembly session. So when you have legislative priorities like this, it's important to follow them throughout the year to see how our government and our administration puts them into practice. And so Catalyst did oppose one bill this session, HB 537. This would have prohibited water fluoridation across the state in public water systems. And we're very happy to share that with the help of quite a number of you all in our network. Virginia proposed a fluoride ban that failed in subcommittee with a unanimous vote. We had a really great show out through our email campaign. You all saw through our newsletter likely. Collectively sending 1,140 emails letting legislators know why they should support community water fluoridation. So I thank you all for that. I did pull this 1-minute clip from the hearing to share with all of you who might not have been there to watch, just because it illustrates perfectly why we do what we do as oral health advocates. Oops. And so that's Delegate Shin live fact checking fluoride misinformation mid-hearing directly from the CDC website. Confident in the decades of research that show the value of fluoridated water to public health and the oral health equity. And that's exactly what we want to see. That's how we prepare for bills like this to pop up. We are consistently educating legislators on why we have these public health measures, and that showed in this unanimous vote this session. And thank you all for your support on that. I know the legislators heard you loud and clear. I've also singled out 2 more bills to be aware of that have been center stage in oral health policy discussions this session. Sister bills HB 970 and SB 178 would create a new preventive dental assistant certification that permits supragingival scaling and coronal polishing. And then HB 1036 creates a pathway for foreign trained dentists with specific qualifications to gain licensure as a dental hygienist at the discretion of the Board of Dentistry. Both of these proposed changes have passed both the House and the Senate and will be sent to Governor Spanberger for consideration. So we want to let you all know that should they be signed into law, Catalyst will be looking deeper into any impacts on the oral health workforce, access to care, patient outcomes as a result of this legislation. We know that there's been a lot of in the weeds conversations among oral health professionals on this. And so I just wanted to stop and ask if there's anyone here with any questions on these legislations or Catalyst's approach while we're on this. We encourage folks with our professional organizations and oral health professionals with this expertise to join this conversation. So we encourage you to engage in that. And if you have any concerns, the correct place to be directing that right now is to the administration's office.
I'm just curious, Lauren, was Catalyst supportive of both of those bills that you just talked about? The dental assistants as well as, the international dentists getting dental hygienist licensure in the state?
Yeah, so Catalyst made a very conscious decision not to take a stance on either of these bills. We were not in support or against these bills, specifically because we're focused on policy and advocacy specific to oral health, but we're not an organization that has the clinical expertise that like our professional organization partners have. Our expertise doesn't really lie in scope of practice issues, and that's what we saw in these bills and in a lot of the conversations. So I spent a long time monitoring these bills and listening to the conversations on either side for and against these bills. And I think what Catalyst positions is to analyze what the impact of this bill is, should it go into effect, and amplify those conversations. But myself, as a public health person without an oral health license or education, I don't feel comfortable taking a position on either of these bills. But I did learn a lot listening to the conversations, and I know with the track that they're on, where they are likely to go into law, we will be looking closely at how they're administered and how the Board of Dentistry approaches this. So if anyone here has any thoughts about that or has any conversation they'd want to have about that here, feel free to come off mute because I'd love to hear it. I'm not going to put anybody on the spot on this, but I also I don't want to make anyone feel like we don't need to have this conversation. But I'll move forward if that's all. So the rest of the body of legislation that we have been in support this session is a little bit more broad across impacting the health system and the social determinants of health. The bill is moving really quickly right now. I updated this slide deck last night, and I think a lot of motion has happened even during the day today, so some of this might be dated now. So some affordable housing legislation that is part of the Spanberger package has already passed through the GA, and that will be going to the governor's desk to likely be signed into law. And we are fully supportive of legislation that keeps Virginia's most vulnerable secure in their housing, specifically because housing security is such a strong determining factor in access to healthcare and many different health outcomes, including their oral health. Our unhoused population is a very high risk population for oral health concerns, and anything that we can do to keep people housing secure is of interest to us. So a few bills are in the middle of a conference process to negotiate out some differences. I kind of pointed out the contraception access legislation being considered and the affordable housing zoning legislation. The rest of the legislation we're still watching are moving through the chambers, getting considered in committees as fast as they can get through it in the House and the Senate. Some with amendments or substitutes that might require a really rapid conference committee. So we are excited to still be seeing that paid family leave, medical leave, and paid sick leave are still in the conversation. And there is still a work group studying 340B impacts out of that legislation. Kind of falling back over onto this slide, you can see what's still in the Senate. The paid family medical leave that is there, the paid sick leave is there. We are disappointed that legislation that would have studied and integrated community health workers and Medicaid managed care cases did not advance this year. This would have been directed towards their high needs patients, patients with disabilities who are under the Medicaid managed care cases to help meet their needs and help control costs where it can be done to connect them with community resources. So we do hope to see community health workers back on the table for Medicaid services in 2027. You can see that Senate Bill 275, that is our community health worker expansion for Medicaid managed care cases, is being continued to 2027. So we hope that that is an active conversation next year. And I know that that's kind of like a lot of bills with not a lot of information on one slide, and reading closely through bills can kind of make your eyes cross. So this is just like a broad summary of what we're seeing this session. Virginia reaffirmed the public health value of community water fluoridation. We're closely monitoring oral health workforce proposals around expanded dental assistant certifications and the dental hygiene licensure pathways for foreign trained dentists. And we're seeing clear commitment from the administration on affordable housing solutions, affordable drug pricing strategies. And finally, we are seeing movement on regulation, expanding access to paid leave for workers, that making healthcare access possible for many working families through that leave so that they have the wraparound services to get to their appointments. And from there, I'm going to transition over into budget proposals unless anyone has any more questions related to some of the bills that you saw. So shifting over into the budget. So once again, this is a great graphic from the Commonwealth Institute that I can spend many, many minutes looking at. I like to start at the beginning, like I said, and look through what can be sometimes a murky process. So the governor releases a budget at the end of the year. We saw that from Governor Youngkin back at the end of 2025. And now the new administration gets to make their mark on that budget. That original budget from the governor at the end of the year was composed of requests from numerous stakeholders who benefit from state funds. And based on the feedback and the responses from that starting point, legislators propose amendments to change the language or add and subtract dollars for various projects and institutions. So the House Appropriations Committee and the Senate Finance and Appropriations Committee consider the amendments proposed in either chamber and put out their own proposals on what's called Budget Sunday, which was the 22nd. From there, the full chamber makes any last minute changes to their chamber's proposal and vote on the proposals. The House and the Senate vote on each other's proposals in a kind of budget crossover. And inevitably, the chambers disagree, and there are differences between the House and the Senate versions. And so every year, a conference committee is formed of members from both the House and the Senate to hash out a compromise proposal. And so we just officially identified our conference committee members yesterday as we're recording this webinar. And when those conferees release their budget proposal and the House and the Senate both vote to approve that conference budget proposal, that's the proposal that goes from the General Assembly that is communicated to the governor. So from there, the governor has the power of the line item veto, where she can take out certain items that she doesn't want in there, and she can propose her own amendments. And when the General Assembly goes through that feedback and votes to approve a final budget proposal that incorporates all that feedback, and everyone has come to an agreement, that is the budget that gets signed into law. And so we have dates associated with these things, but of course that can become more complicated than it already sounds and looks on this graphic. So right now the conference committee members identified yesterday will be digging into the two proposals that we have from the House and the Senate, and they'll be deciding what from each proposal should be included in the final version. And so I'm going to talk a little bit about what we would like for them to carry forward into that. And I'd like to start out with some wins, some investments that are included in both the House and the Senate proposals. So a new VCU School of Dentistry building remains in both versions of the originally proposed Governor Youngkin's original budget bill. So we're also happy to see that an additional $5 million per year is allocated to support our free clinics through this period of increased pressure on their safety net clinics. And I'd like to note that that is in addition to the funding that they had on a normal year. So this is to support that additional burden that we're expecting to see as a result of HR 1. I'm also happy to share that the famous prenatal and postpartum coverage that was taken out in the original version of the budget has been restored to certain immigrant groups. So that program is still available to all Virginians. Both proposals also include numerous investments in a range of affordability housing programs, so many that I didn't try to put them on this slide, but there are significant affordable housing investments there. And then the federal tax credits that subsidize the ACA marketplace health insurance plans did expire at the end of 2025, and we're not likely to see reinstatement from the federal government anytime soon. Just my 2 cents, and apparently the 2 cents of our General Assembly, because both House and Senate took a stab at this problem. It's a Spanberger priority to address any rises in premiums for families affected by this. I've summarized the differences between the House and the Senate plans here on this slide. So the Senate proposal puts $200 million, a significantly larger investment to offset costs for families with ACA marketplace insurance. So that's for all families below the 400% of the federal poverty line level, with the goal of maintaining the level of affordability that they had prior to the expiration of the tax credits last year. They're also hoping to expedite that support by opening up a special enrollment period this year, if possible, to get those funds to families as fast as possible, if that ends up being feasible. On the House side, they had fewer funds to work with just based on the revenue that they found in their budget. They chose to target families between 138 and 200% of the federal poverty line, with a more flexible and modest goal of price reductions based on fund availability. So that income range was likely targeted because that's the group that's been projected to see the most notably higher premiums with the loss of the tax subsidies. So this was like a need-based decision. So we would like to see, we as Catalyst, as much investment as possible in affordable healthcare coverage for these folks who need it. So we'll be advocating in favor of the larger investment in the Senate proposal as the conferees negotiate the final proposal, but we can expect to see some support there on our health insurance premiums. So that's all the really great news. I don't know if anyone has any questions on those before I move on to the next batch of budget items. So the next batch are budget amendments that are the ones that are currently only included in one of the budget proposals. So this is where our attention and advocacy is most needed to ensure that these investments we would like to see in the health system are included in the final budget. So we see this trend of more investments in the Senate proposal, largely because they had the larger revenue available in their budget. So we're thrilled to see some investment in the proposed dental hygienist funding pool. So this would be a public-private partnership creating a matching fund for projects increasing the capacity of community college dental hygiene programs around Virginia. This is being led for Delta Dental too. Community college dental hygiene programs will be able to apply for these funds to grow our dental hygiene workforce. This will also be a great way to workshop models for expanding programs statewide should we want to move forward with a larger scale model. We also see a $50 million investment in drinking water infrastructure for Virginia that creates a regional water work group for the projects specifically in the city of Richmond. We're anticipating a large investment to be made here in Richmond. And the Senate is looking to increase the age that young people can retain their CHIP coverage from 19 to 21. So that's just to avoid those young people dropping off into that young and uninsured category. And then finally, there's a proposed provider development incubator program intended to expand capacity specifically for providers serving people with disabilities who receive waiver services. This is more of a modest investment. It's in the ballpark of $700,000. But it's a great starting point to help target the people with disabilities who tend to disproportionately be affected by the cutting of optional Medicaid benefits when budget issues come around. There's also one sizable investment for the community college system included in the House proposal that we're in support of that aims to increase student capacity of a number of health science programs. It is a $30 million investment, which is a good chunk of money. But these funds will be split across the included disciplines in the budget amendment. Dental hygiene programs are included in the amendment and will benefit from some of this investment, but we can't tell from the budget item what the itemized investment will be for dental hygiene programs specifically. Regardless, we're happy to see investment in our health science programs at the community colleges. And so Catalyst will continue to advocate for these amendments to be carried forward into that final budget. And we'll keep you very updated pretty soon on how you can get involved in that process. Are there any questions there on what is in the budget? So I know some of you have already reached out, but I'd like to invite you now to ask any questions that you might have that's related to this $2,000 annual cap on the Medicaid adult dental benefit, which is still included in the House and Senate proposals. So fighting this cap has been Catalyst's top priority. And I have a lot of information on this for you. The budget climate hanging over the session has the Medicaid program under the microscope and a target for spending cuts wherever they can be found. And right now, capping the adult dental benefit services is still among those cuts. Legislators are especially challenged right now with the requirement to balance Virginia's budget this year. And fiscal impact from this cut to the adult dental benefit is not insignificant, one of them to factor in. You can see the fiscal impact figures here in the budget amendment we've been supporting here. So we want to thank Delegate Willett for his amendment to strike the cap and his steady support of oral health services and workforce initiatives. When we zoom out to look at dental benefit caps in other states, the $2,000 cap level is classified as the quote unquote extensive, with the most standard members not exceeding this amount, making it a difficult one to challenge. But patients with higher needs or special needs in the dental setting, especially folks requiring anesthesia or surgical interventions in their treatment plans, are the ones we're most concerned about hitting this cap and going without care that is really necessary to maintaining their health. Catalyst remains committed to our advocacy for a true comprehensive dental benefit for all Virginians because oral health is an essential component of overall health and it's not an optional benefit to be restricted. We continue to educate legislators and the Spanberger administration on the harm a cap would have on patients, providers, and the healthcare system as a whole. And we're doing what we can to preserve access to care. We also want to keep you all on the loop on what our plan is moving forward in this scenario. In order to be best equipped to reverse this cap later on, we would need a strong body of evidence that shows how patients, providers, and the healthcare system is impacted. So we're prepared to prioritize data and story collection statewide that documents patient experiences, the barriers for providers through the claims process and complex treatment plans trying to complete the care your patients need, and the fiscal impact from reduced coverage for high needs patients in a lot of these clinics that are under stress right now. So we will be digging into what flexibility we have in administering this cap that protects coverage for our high risk patients and simplifies the process for providers as much as possible. We'll be working really closely with DMAS to figure out the details and communicate those as we know them to you all, and have a plan in place should this go into effect. But we will continue to fight any restriction on healthcare coverage. We know that we knew that defending our dental benefit would be a long-term priority as these budget impacts from HR1 manifest. So we'll organize and we'll continue to increase our advocacy capacity as a coalition to meet that moment. And as always, we'll keep this network in the loop on how you can support that effort. Legislators always value hearing expert voices, so I encourage you to remain engaged on your own in your own practice and in Catalyst campaign, and to continue reaching out to legislators and the administration on your concerns. So that's the information that I have right now, and we'll be touching base pretty regularly as we learn more about what this would look like and what we can do moving forward. But does anyone here have any questions or any comments to bring up on this?
Lauren, I have a question. So if this proposal goes forward, what happens to the patients after they hit the $2,000 cap?
So my understanding is it's as if they don't have coverage for the services. So for someone who hits their $2,000 cap, that might be mid-service, that would become an out-of-pocket cost to my understanding. And that's what is really dangerous about shifting cost burden onto those clinics that are providing care for these patients, especially for patients who do need more extensive treatment plans, is because even determining when that cap hits while the claims are going through can be a really complicated process. And it's something that we're going to work really closely on DMAS on to make sure that if this does go into effect, there is a system that is streamlined for providers and doesn't penalize providers for providing the care that their patients need. But it really is similar to state and private plans that also have caps like this on them. That is just your coverage for the year. And then it becomes something that you pay out of pocket.
And would that be out of pocket using the Medicaid rates that, the providers, signed up for, honoring those rates as opposed to their, fee for service rates?
That's where I'm not sure. The cap that's been provided, the section is very short and vague, which means it might lead quite a bit up to DMAS and how we choose to administer this. We have quite a bit of information on how this has been done in other states that helps to decrease costs and maybe do like what you said, honor the Medicaid rates versus higher like value cases. But that's something that I'll be talking with DMAS next week about this a little bit as well, to learn a little bit about what we can do within the confines of what this code change says. How can we carve out services and administer this in a way that's more equitable for those patients who need those services and genuinely can't afford to pay for something out of pocket. So that might be a conversation that we can have as we talk about administering this. But it's not specified in the legislation when this goes into effect. So we can assume that this will go into effect July 1st, should it pass.
Thank you.
Mm-hmm. Does anyone else have any questions or anything that I can dig into that I should make note of?
Lauren, I'm just curious, like in your conversations with legislators, is there like a certain line that seems to resonate the most with them? Is just looking at your slide on what's on the right side here, like as far as, I don't know, like special needs patients or just like, cost or anything like that? Like what seems to resonate the most with them that may be the most effective for us to kind of have conversations about as well.
Yeah, I mean, the case that I've really been bringing to them are these patients who the only way that they receive dental services is in, a surgical setting under anesthesia, where that $2,000 cap is just not a realistic cost basis for them to receive adequate care. But the most effective argument to be making for these legislators who are serving, an entire district, an entire state, is the fact that this is really something that only adds administrative burden for our providers who want to be providing services to Medicaid patients. We already don't have enough Medicaid providers in our system. People can't get appointments. People with private dental insurance can't get a dental appointment in 6 months the way that they'd like to. And that's especially not true for Medicaid patients. And the idea that administrative burden is one of the most common reasons we hear from providers who don't participate in medicine in Medicaid, why they don't want to get involved in that program. Adding to that complexity and that headache of getting your claims and going through that process of having to stop mid-treatment plan because your patient hit their cap, that's going to be likely detrimental to our Medicaid workforce. That's going to be shifting cost burden onto the clinics, which is a large conversation that's happening in session right now, is how do we relieve that burden from our clinics and our hospitals, and keep their doors open for all these patients that need their services. So making that argument that this is going to create a systemic problem, the system is going to be less efficient, the system is going to be harder to use for our providers, that really drives home the fact that this is going to create a problem. We simply just, we don't have evidence ahead of time to show them that that's the reality. So if the reality is that this goes into practice and we collect the data to show them that it's a mistake and roll this back next year, that's what we'll do. But that's the conversation that I've been trying to drive home with them, is that this is just reversing, this is going in the opposite direction for the healthcare system that we want to go in.
Thank you.
Is there anything else before we move past this? Well, this remains our number one priority, and we'll be paying attention and doing everything that we can to make sure that any harm is minimized, and we avoid any restrictions on the access to care that we've succeeded in this state so far. So with that, shifting to something that's a little bit more hopeful, more of a silver lining for us. I have a little bit of details on the Virginia Rural Health Transformation Plan. I took a couple slides from a recent Health and Human Resources presentation to share with everyone. And I'm happy to share the full presentation if you want to dig a little deeper into this. As you might remember, HR 1 from last year included this program that allows states to submit proposals for funds that go towards certain types of rural health investment projects. This would be an opportunity for us to fund IT and workforce development, innovative pilot projects, and build up our rural healthcare systems within the parameters provided by the CMS. Unfortunately, the program is not designed to support direct clinical services or fund our rural clinics directly. This is not intended as a plug the hole type of fund. This is meant as an innovation fund. So this is just a slide that covers an overview of Virginia's initiatives: Care IQ, Homegrown Health Heroes, Connected Care Closer to Home, and Live Well Together. And you might remember our push to raise oral health during the listening sessions last year while Virginia was forming its proposal. The administration heard from you all at every single listening session around the Commonwealth, and they made note of it. They let us know that they heard you all. So thank you all for showing up there. The oral health workforce shortage was mentioned in the proposal sent to CMS. And I've noted some points here with green arrows where dental hygienists were identified as allied health professionals who can be targeted in the Homegrown Health Heroes initiative. So this is an opportunity to draw funding into our workforce pipeline. Any innovative practices, any healthcare integration models that we're trying out across the state, these are the kinds of projects that this money can go into. So this is still very much in the works. It's taking shape. Catalyst will be closely engaged as these initiatives get off the ground and start to take a form, so that the oral health workforce and our rural clinics where they serve are included in this opportunity. So I encourage you all to look more closely into Virginia's proposal on the Rural Health Transformation Program. This here is a more granular look at what exactly each initiative includes. There's quite a diverse range of projects here that could be tailored to innovative oral health projects in workforce development. So I'll try to share out this presentation in full with the recording of this, and hopefully you all can look at this and kind of get your gears turning about how this might be supporting some of the projects you're already doing, because I know there are a lot of folks out there in the rural areas of Virginia who have really innovative models that might be able to draw some funds from this. And so what's next? Where do we go from here? The budget conference committee members were announced yesterday. So we have this official list in front of you who will be deciding of the amendments that we discussed today, what will be included in the final budget. So if you were wondering who to share your experiences with, who to reach out to, this list here is the offices you can reach out to on your own to encourage health system investments. These are the people who are making the decisions right now. And as always, Catalyst is here as a resource. We'll continue to lead that advocacy initiative and share out any updates or opportunities for you to join in on that joint effort. We're in the final push now to make sure that these initiatives make it all the way into the budget. So the House and Senate will continue to rapidly vote through bills in the final days for committee action. And then we will be back for more information when Governor Spanberger provides her feedback on this year's legislation. Senate is set to adjourn next Saturday, the 13th, and return on April the 22nd. And that's when the General Assembly will have that opportunity to respond to the governor's feedback on their legislation and the budget. And we should know a little bit more on what will be included in the budget going forward for 2027 and 2028. And thank you for taking the time to engage with legislative process and giving us your attention however you're able. If there are any more questions about policy, the General Assembly, anything we've got going on at Catalyst, please let me know. Otherwise, we will keep you updated on any calls to action to support our policy work that'll be coming up super soon. And we'll be sending out this presentation for you all to look back on. My email is here if you want to connect or you think of any more questions about anything that I've talked about. And I hope you all get out and enjoy your mini March summer and have a really great evening.